talk to probiotics in adult gastroenterology. And this is really an extremely exciting area. It was a pleasure to listen to Professor before me when he talked about C. diff. But there are lots of areas beyond C. diff where this actually works very well. And let's go through the list. The good news is that the role or the areas in which probiotics may work in gastroenterology is pretty long. It includes inflammatory bowel disease, antibiotic-induced diarrhea, these things we are aware of, infectious diarrheas, slightly less uncommon conditions in which these were used like diverticular disease and collagenous colitis, celiac disease, IBS, hepatic encephalopathy, and there are even more actually. It can be used in pancreatitis, in small intestinal bacterial overgrowth, and also in our friend Helicobacter, the one that causes ulcers. But what's the difficult part? The difficult part is that, is there in fact any evidence at all? How good is this evidence? Much more important than a single paper, has this evidence been replicated in diverse populations all over the world? And the final question, which we often forget about, is this clinically relevant? If you can actually bring down bacterial population to a significant degree, but your patient still dies on you, well then it's of limited clinical value. What I'm going to do is run through these conditions. I'm not going to go into enormous detail about studies. This is more an overview than specific paper discussions. Inflammatory bowel disease, is there a conceptual basis for its use? The answer is yes, because if we have, say, 500 species of bacteria in the gut, and the pathogenesis probably involves dysbiosis and an abnormal immune host response to this dysbiosis. So what can we do about it? Well, inflammatory bowel disease, I'm going to talk about three components: ulcerative colitis, Crohn's disease, the two classic IBD entities, and an extremely important entity called pouchitis, which is a result of surgery for UC. There are a lot of studies done in the induction of remission and maintenance of remission. What I'm going to do to actually make it just easier is going to talk about a study done in India. We're talking about an Indian population, and this was a very nice study that was done by Ajit Sood from Ludhiana and Govind Makaria from the All India Institute of Medical Sciences, where Professor Rakesh Tandon actually incidentally was director of that department. And this was a great trial which involved patients with mild to moderate ulcerative colitis given a twice daily probiotic mixture versus patients given placebo. And there was a significant difference. The primary endpoint, if you used a commonly used index called the ulcerative colitis disease activity index, there was a 42% versus 15%, which is with a significant p-value. So clearly there was some benefit from this. And this was very exciting because UC is, at the best of times, not an easy disease to treat. But what is the overall picture? And I'm going to be fairly candid about this. Remember, our data is limited. Our conclusions have to be robust. So I'm going to state that there is actually insufficient data to support the use of probiotics in inducing remissions in ulcerative colitis. There are underpowered trials that show some benefit. And of course, this extremely exciting story about fecal microbiota transplantation, which unfortunately I wish I had a lot of talk on this because it's a really exciting area. There has been definite evidence that this does help in some people. What about maintenance of remission, which is actually a much more important thing? Remember, people, if you look at the natural history of ulcerative colitis, people are going to be in relapse only a short time in their lives. Most of the time, they're going to be in remission. Can you maintain remission with probiotics? Well, one study showed that it was as useful as the standard medication, which is 5-ASA. But once again, the proof is lacking. The proof is actually much more convincing in this condition called pouchitis. And for people who are not kind of into gastroenterology, remember that because ulcerative colitis involves the colon, the only curative treatment is a total colectomy. Having done a total colectomy, you can actually create an ileal pouch and anastomose it through the anus. So it's called an ileal pouch anal anastomosis. Now, unfortunately, almost 50% or more of these patients develop an inflammation in the pouch called pouchitis. And there are many studies that have shown that probiotics are effective in the maintenance of remission in patients with pouchitis. Now, this is extremely important, and I really want to emphasize this because remember, for the first time, we were able to create a situation when you can cure ulcerative colitis and not give someone an ileostomy. In other words, they passed the stool from the normal passage. The problem was the pouch was getting inflamed, and if probiotics genuinely can prevent that, and I think they can, then we're really onto something good. Crohn's disease, unfortunately, the evidence is still not that great. There is insufficient evidence in in three areas: in inducing remission, in maintaining remission, and most important, once someone has been surgically operated and the remission is because of a post-op state, then to keep them in remission post-op, the evidence is not strong enough. The evidence is there, but it's really not that strong. And even in Crohn's, I mean, I have not personally done a fecal microbiota transplantation, but the evidence is striking in some patients in whom you've tried everything and it doesn't work. The one area in which I think we all agree probiotics will help will be antibiotic-associated diarrheas. The incidence is almost 40%, with a higher rate in hospitalized patients, and about a quarter maybe because of C. diff. Now, there are a bunch of randomized control trials which confirm the value of probiotics in the prevention of antibiotic-associated diarrhea, particularly Saccharomyces boulardii and Lactobacillus. And there's a single RCT using Lactobacillus and Lactobacillus casei, which significantly prevented the C. diff. Amazingly, the ultimate answer for an uncontrollable C. diff diarrhea is still a fecal microbial transplantation. It's amazing. It works. These people walk out of hospital the next day. This was emphasized by our previous lecturer, but it actually, it's striking the way. And these are very sick patients. You know, your options at that point are a total colectomy in a sick patient with a low albumin. This is really exciting. What about infectious diarrhea? Something far more common and something much closer to home. The last Cochrane review of 63 trials showed that you can actually reduce the duration of diarrhea by 1 day, that the risk of a diarrhea lasting than 4 days was reduced by almost 60%. But then this was a bunch of studies with variable probiota that were used. It was difficult to find out which were the good ones. Overall, I have no doubt in my mind that these will work. We just need to identify which ones. Diverticular disease is something that is really not so well recognized in India, because for some reason our diverticular disease rates are slightly lower. And unfortunately, there's a bunch of patients with non-specific abdominal complaints who may have divertically. And a causal relationship is difficult to establish. But this was often called SUD, which is a symptomatic, uncomplicated diverticular disease. The role of probiotics in this is not proven. But remember, if you're talking about colonization of the diverticulum with bacteria as a cause of diverticulitis, which is a common disease in the West, then theoretically changing that the microbiota of the gut should reduce the risk of of plain simple diverticulosis becoming diverticulitis. We're not right. Diverticulosis alone is not an issue. Lots of people have it. It's the infection in the diverticulum that causes problems. And I think conceptually there is no reason why some probiotics should not work in preventing or treating a diverticular infection. This is a rare disease, and I bring it up just for information because it's a very difficult disease to treat. And this is a condition in which generally seen in elderly ladies, in which there is ongoing watery diarrhea. You colonoscope them and it's completely normal. But if you biopsy them, you find either evidence of inflammation or evidence of a collagen band. It's difficult to treat this at the best of times, but there are reports of probiotics helping, but once again, there is no absolute proof that it works. But I bring up this slide because it's potentially an area that should work. Well, we are all aware of celiac disease. It's a condition of gluten toxicity, and the only effective treatment is complete avoidance of gluten. There are studies that have shown that in addition to a gluten-free diet, you can actually add probiotics, and they probably will help in regeneration of villi. Now, I want to emphasize once again, please, the treatment of celiac disease is a gluten-free diet. The treatment of celiac disease is not a probiotic. But if a probiotic can help, that will obviously be of benefit. The last studies done in this country show that celiac disease is clearly not as uncommon as we thought. It's much more common than we think. And we're talking about rates approaching 1%, which is a significant number. The commonest intestinal disease by far is irritable bowel syndrome. This is a functional bowel disorder. It has three components. You can get it with constipation called IBS-C. You could get it with diarrhea called IBS-D. And as with all with the art of gastroenterology, when you don't know what is going on, you call it IBSM, which is mixed. A meta-analysis have shown that probiotics as a group do have a beneficial effect. Specific strains actually do benefit patients, and I think this is an area in which we are all using it, to the extent that many recommendations now include probiotics in the treatment of irritable bowel. They appear to be more effective in flatulence and bloating than in constipation, but this is something that as clinicians, and I'm sure all of us in this room have consistently and often used probiotics in the treatment of irritable bowel, not always with great results, but often with good results. And as with anything else, if we refine it, I'm pretty sure 10 years later, this is where the answer will be. Hepatic encephalopathy is, as we're aware, a syndrome of neurologic and psychiatric manifestations in people both with chronic liver disease and in some patients with acute liver disease. And the last Cochrane review actually analyzed a large number of trials. It did not prove that probiotics can help conclusively, but it did prove that there was a reduction in plasma ammonia levels. As we are aware, there is a reasonably good correlation between plasma ammonia and the grade of hepatic encephalopathy. So once again, theoretically, we are on the right path. And this is an area which I personally believe will actually make a difference. I would like to bring up the slide. This is an extremely important slide. This was pancreatitis, as we are aware, is a potentially life-threatening disease. And in a Lancet study in 2009, probiotics did not reduce infectious complications, it actually increased mortality. Now, why did that happen? And this is actually a slightly wake-up study for all of us. And I think the reason was two things. Number one, this was a septic patient, or these were septic patients. And number two, in septic patients, particularly when the pancreatitis is alcohol-induced, there was a clear reduction in immunity. So I think the moral of the story is that if you've got someone with reduced immunity who is septic, then adding even a good bacteria is likely to make it worse rather than better. So I think we need to be careful about it in people who are very sick with possibly reduced immunity. And therefore, the message from that study was very clear that probiotics should not be used in acute pancreatitis. SIBO is small intestinal bacterial overgrowth. Two things happen. There is overgrowth of bacteria in the small intestine, and there is some associated malabsorption. Obviously, if you've got bacterial overgrowth, the logical answer is to use a probiotic to suppress these bacteria. It is far more logical than using rifaximin or some other antibiotic, even if it's non-absorbed. Very strangely, the number of studies showing this is limited. But as a concept, this makes sense. And I'm willing to guess that, in times to come, this will actually be a major treatment of small intestinal bacterial overgrowth. Helicobacter, all of us are aware, this is a bug that lives in the stomach and is associated with ulcers all the way up to adenocarcinoma. Now, Helicobacter is conventionally treated with a triple regime, but it has been shown that in 7 of 9 studies that the density of the Helicobacter actually decreased with probiotics, and the addition of probiotics to the standard regimes actually seemed to increase the Helicobacter eradication rates. I think many of us are using it in any case, and the reason we use it is that 2 of the antibiotics that are used for treating Helicobacter very often induce diarrhea. We are often using amoxicillin and clarithromycin. In many patients, they'll get diarrhea as a result of the antibiotic, and the probiotic will often control that. But whether the probiotic is also killing or reducing the H. pylori, that's something that really is exciting. And as I said, this really requires a separate talk. But this bugs versus bug story is, I think, the greatest revolution that has happened in the last few years. This is definitely going to be of value in inflammatory bowel disease and in C. diff disease. It's possibly now the most effective treatment for C. diff eradication in a patient non-responsive to vancomycin and metronidazole. It may be of benefit in IBD. In fact, it should be of benefit in IBD. And finally, therefore, what is our conclusion? Remember, probiotics are probably of value in inflammatory bowel disease. They are clearly of value in pouchitis, and we all use them in pouchitis. They are definitely of value in some patients with antibiotic-associated diarrheas. They are probably of value in Clostridium difficile, particularly if you use fecal transplants. They can perhaps reduce infectious diarrheas, and I'm sure they're going to be useful in irritable bowel. In the future, they're going to have a role in hepatic encephalopathy, in small bowel intestinal overgrowth, and probably in H. pylori. And I'm going to end by a quotation from Lord Buddha, which I brought because I think not only in probiotics but also in everything else connected with science, we need to think about this carefully. And remember what he said, and I'm going to read it for you. He said, "Believe nothing, no matter where you read it or who said it, even if I said it.